Hello, I'm Kirsten DeWitt. I'm an emergency physician and thrombosis physician in Canada at Queen's University, and it's a pleasure to present an update on this project, which is developing standards for diagnosing pulmonary embolism and lower limb deep vein thrombosis in people with cancer. My only conflict of interest is a Bayer research grant in 2016. We started this whole project in 2019 in the SSC meeting in Sydney. We started off with a needs assessment, which was a survey of the audience, and these are the findings from that survey. Firstly, the respondents felt that sometimes testing for venous thromboembolism in people with cancer should differ from people without cancer. 3/4 of respondents thought that clinical probability does have a role in testing for people with cancer, and 2/3 thought that D-dimer also should have a role in testing people with cancer. However, there was still a large minority of people who felt that diagnostic imaging was the only appropriate first test for people with cancer. In the last year, we've performed a systematic review and meta-analysis. This systematic review aimed to identify all the existing literature on diagnostic accuracy of any tests for either lower limb deep vein thrombosis or pulmonary embolism in cancer patients. We started off with almost 8,000 manuscripts, and we ended up reading 49 full text reviews, and in the end identified 13 publications reporting on patients with cancer. 11 of those publications reported the diagnostic accuracy of D-dimer, and 4 of them reported the false negative rate and efficiency of combining D-dimer and clinical probability to exclude venous thromboembolism. You'll notice at the bottom there that 2 publications reported both of those: diagnostic accuracy, efficiency, and false negative rate. These are the results that we found. These are the results for the sensitivity and specificity of D-dimer. First of all, we've grouped by PE sensitivity, then PE specificity, followed by DVT sensitivity and DVT specificity. And sometimes it can be helpful just to look by eye at these results, and you can see that D-dimer is highly sensitive for both pulmonary embolism and deep vein thrombosis. The specificity of D-dimer seemed to vary, and it seemed to vary somewhat depending on whether the patient was tested for deep vein thrombosis or pulmonary embolism. When we take a deeper dive into these studies, there were 2 very large studies that constituted the pulmonary embolism data. Both were conducted in a single emergency department in Texas, which primarily served oncology patients. And when we look at the risk of bias for these studies, unfortunately, those 2 very large studies had the highest risk of bias, both in patient selection, because they simply included a patient if they had a D-dimer without the knowledge of why the D-dimer was performed, and also looking at the reference standard testing. There was no definition of how they ruled in or ruled out either DVT or pulmonary embolism. About half of the studies were retrospective, and we rated them as having a high risk of bias in patient selection. But on the whole, the studies did clearly report the D-dimer test that they used. They did clearly report how they diagnosed and excluded venous thromboembolism and the timing in between the test and the reference standard. This is another visual depiction of exactly the same studies. We used a bivariate pooled estimate for sensitivity and specificity. So overall, for both PE and DVT, D-dimer had a sensitivity of 96% and specificity of 26%. And then when we looked at the studies that only analysed pulmonary embolism, sensitivity remained high at almost 97%, but a very low specificity of 14%. For deep vein thrombosis, sensitivity was 94% and specificity moderate at 46%. This is a visual depiction of the data reporting the efficiency of combining D-dimer at a standard cutoff with a low clinical probability to exclude either pulmonary embolism or deep vein thrombosis. Overall, the efficiency was 9.3%. And last of all, these were the results for the false negative rate of combining D-dimer with low clinical probability. Unfortunately, we only have 122 patients in this analysis, so we really couldn't do a meta-analysis. There was only 1 case of false negative, so someone who was diagnosed with VTE within 90 days of their testing. So in summary, D-dimer is highly sensitive for excluding venous thromboembolism in people with cancer. D-dimer has a low specificity for pulmonary embolism and a moderate specificity for deep vein thrombosis. And the efficiency of combining D-dimer with a low clinical probability is kind of low at about 9%. So we also conducted interviews with physicians and patients. And the aim of these interviews were to explore how they are currently testing, barriers to following evidence-based testing, and patients' values and preferences. We wanted this to be an international study, so we actually recruited physicians and patients from around the world in as many of the continents as possible, including North and South America, Europe, Africa, Asia, and Australia. We had 24 physicians from all specialties, even including radiology, oncology, hematology, internal medicine, and emergency medicine, and 6 patients. So from the physician interviews, these were the following themes. First of all, physicians felt that patients have a very high risk of developing venous thromboembolism, so they actually had a low threshold for testing these patients. They also felt that pulmonary embolism was a dangerous diagnosis that was potentially fatal, which also motivated them to have a low threshold for testing.
And therefore, consequently, I think if one had a negative Wells and a negative D-dimer, I think you're duty-bound to carry on pursuing, even in those cases, because of the chances of having clot during cancer being so high.
On the whole, the physicians who were interviewed felt there was only one test for venous thromboembolism in people with cancer, and that was imaging. They felt that D-dimer and clinical prediction rules were irrelevant, given that patients have a large amount of radiation anyway. They felt that these were not validated tests for excluding VTE in cancer patients, and they often just expected that D-dimer would be high, and it was simply going to delay ordering an inevitable scan. They commented that there was poor face validity for both Wells and Geneva scores because they lump all cancer patients together without differentiating between them. And on the whole, it never really crossed their mind to use clinical probability and D-dimer to exclude the diagnosis, and generally saying that those tests were for other doctors and not for them. So most physicians simply used their gestalt to decide to test, and when they were going to test, they would use a scan.
What I would not do with somebody in this situation is get a D-dimer, not for someone with an active cancer.
Well, yeah, I think I pretty much always do, because my only other alternative would be to do a D-dimer, and I don't trust a D-dimer in cancer patients. If it comes back negative, I'm not necessarily convinced that it's not a false negative, and if it comes back positive, I'm no further ahead than when I started, and I had the patient wait even longer.
But I would just not really be comfortable with a patient's obvious signs and symptoms that resemble a DVT. And then when I do a Wells score, it doesn't seem to, predict that a patient does have a DVT. And I just decide to gloss over it and decide, okay, I don't think it's a DVT. It's just something that I would not personally be comfortable with.
On the whole, the physicians felt that a single scan was a standalone test. So generally, they had no plans to repeat it. And generally, they would not combine the interpretation of the scan with either clinical probability or D-dimer.
If I think it is a PE or a DVT and they've got cancer, then you just scan them.
A CTPA is not going to kill them. A CTPA might actually give you the proper diagnosis. Just flipping do the CTPA and get it over and done with.
Importantly, all the physicians we asked said that their colleagues would support their testing behavior. And we know that local culture is one of the largest drivers to clinical behavior.
Oh, yes, yes. We always order imaging. Yes, because we just can't take chances, because it's always better to be safe than sorry.
And then last of all, the physicians really were very interested in the idea of a cancer-specific score that included the differentiating factors, maybe the stage of cancer, the type of cancer, and possibly the type of treatment. As far as the patients went, firstly, they told us that they don't mind having tests and scans.
But to me, blood tests are simply sat there and CT is simply laying there, neither particularly onerous or anything like that.
Not at all. I've had every diabolical invasive procedure known to mankind. This was nothing.
Patients thought it was important for physicians to prioritize testing for venous thromboembolism.
I mean, you don't want to go through cancer treatment and die of a blood clot.
And patients generally weren't concerned about the number of CT scans that they were having. One of the most important themes was that they had ultimate trust in their physician, particularly their oncologists and their family physicians.
And I trust them to weigh the risks and the pros and cons, and if they tell me it's time to go for a scan, then I go for a scan. I don't worry about it.
So to summarize, we found from our physicians' interviews that they had a low threshold for testing for venous thromboembolism in these patients, that they seldom used D-dimer and clinical probability, that they generally didn't trust these tests, and they felt they had poor face validity. And patients have particularly strong trust and confidence in their physicians' testing decisions. So how do we move forward using all of this information to make pragmatic standards? Well, our plan is to perform a Delphi study. Before we start that, I have just one poll, one question for the audience. So I would appreciate if you could open your Slido window and simply choose the most appropriate response to this question, having just heard my presentation. So should there be standards for using D-dimer and clinical probability in patients who have cancer? I thank you very much for your attention, and I look forward to answering any questions and discussing further during the question time at the end of this session.